Thank you for joining us for the second annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. I am Jennifer Jones, and I am a resilience consultant and a United States Marine Corps veteran. I have managed kidney disease for 9 years, with 5 of them as a kidney transplant recipient. I am honored to serve AAKP as an ambassador and member of the AAKP Veterans Health Initiative. Being a part of AAKP means being a part of a real family of kidney patients, caregivers, living donors, healthcare professionals, and supporters who are passionate about improving the lives and long-term outcome of kidney patients through education, advocacy, patient engagement, and the fostering of patient communities. Today, I am pleased to introduce Dr. Claudio Ronco, Director of the Department of Nephrology, Dialysis, and Transplantation at the International Renal Research Institute in Italy, who will present on emerging research in kidney disease with global implications, kidney disease management and treatment, acute kidney injury. We appreciate Dr. Ronco for his taking the time to share insights on acute kidney injury and how timely research and innovation can improve patient lives and society.
Dear colleagues, thank you very much for this kind invitation to Global Innovation in Patient-Centered Kidney Care International Summit organized by the American Association of Kidney Patients in partnership with George Washington University. I must say I'm particularly proud to give this talk because I have been fellow in GW many years ago, and it is very nice now to come back. My name is Claudio Ronco. I am professor at the University of Padova, one of the oldest universities in the world, teaching nephrology, and I'm director of the Department of Nephrology at the San Bartolo Hospital in Vicenza, Italy, and the International Renal Research Institute in Vicenza. I've been asked to cover emerging research in kidney disease with global implications. And of course, we could not give anything more up to date than the management and discussion on mechanism of acute kidney injury in case of COVID-19 patients. First of all, the best regards to everyone from our university. This university is actually going back 800 years of history, and I'm very proud to belong to the university where somebody like Galileo Galilei was a teacher. COVID-19 was considered initially a small epidemic in China and subsequently considered as a problem for Europe, but subsequently it has been demonstrated to become a pandemic, and United States and Latin America have been strongly hit by this disease. Now, we have been studying models of the evolution and distribution of the epidemic throughout the world, and Remuzzi in Bergamo has published in Lancet the effect of distanciation that shows clearly how the blue curve can be differing from the red curve that was the model just by implementing distancing effects. We're not new about this, especially in Venice, close to where I live. We used to have doctors keeping distance from the patients using special masks, and this is a special church for the healed patient after the pestilentia of the 15th century. They even created the term quarantine, and in fact there was an island where people traveling from Far East were stopping for 40 days in order to avoid the spreading of the contagious. Now, we are knowing clearly that viruses can go through species, and we are familiar with the H5N1 and H1N1 influenza. But what we have seen recently with the discovery of the coronaviruses has been the severe acute respiratory syndrome, providing information on a typical pneumonia caused by a virus called SARS-CoV. In 2004, there was an epidemic, but no further cases have been described. At that point, bats and small mammalians were involved, while for the MERS, the Middle East Respiratory Syndrome, again caused by a coronavirus in Saudi Arabia, identified in 2012, camels were considered the source of transmission, and occasionally new cases are seen around the world. This is very important because it has been identified that the droplets were the mechanism involved in contagious. So we're now familiar with the evolution and the jump of virus through species from SARS-CoV 2003, MERS, and finally SARS-CoV-2 from 19 started in Wuhan, China, and now has hit more than 150 countries with an enormous amount of deaths. The first report by official in Wuhan city was in December 2019, while the virus was identified and the genetic sequence was shared publicly on mid-January 2020. In February, beginning of February, we published a paper in Lancet somehow warning about the need for preparedness for extracorporeal organ support in intensive care because it was not possible to anticipate the extent of the epidemic and the number of patients who might require support in intensive care. This is quite interesting because February 6th was just the anticipation of what happened later, what we call a tsunami in intensive care units, where a number of patients were admitted with severe respiratory problems. We're now aware that we may have healthy subjects carrying the virus, or we may have infected virus with mild symptoms, moderate symptoms, and finally severe symptoms that affect the capacity to exchange oxygen through the alveoli. Radiological findings are typical for a pneumonia that may go from non-severe alteration to a very severe and important alteration of the pulmonary structure. And here you see severe manifestation of COVID-19 in a CT scan in a patient with impaired respiratory exchanges. We published in Critical Care quite early the experience of Italy, which was hit quite strongly. And we may say as a conclusion that AKI is frequently observed in patients with respiratory syndrome, especially when they are affected by different comorbidities. The respiratory syndrome associated AKI may be ascribed to several causes, including inflammation, immunoreaction from the host, and the presence of circulating mediators that are somehow defined the so-called cytokine release syndrome. Kidney epithelial cells can be affected by viral infection, which may worsen local inflammatory response and increase the incidence of AKI. And these comorbidities may be associated, of course, with pre-existing chronic decline in kidney function. And we must know that patients who have limited renal functional reserve have a tendency to develop AKI episodes. Identification of patients at risk is therefore important, and we used early detection of kidney dysfunction and damage using biomarkers of the last generation, such as TIM2 and IGF-BP7, called cell cycle arrest biomarkers. Finally, the use of extracorporeal blood purification techniques and antiviral therapies can be somehow combined to try to treat these patients. The virus has been identified in the kidney tissue, showing that the direct damage is possible. However, we published in Lancet few weeks ago this figure where we clearly demonstrate that there are direct and indirect damage to the kidney causing acute kidney injury. There might be a direct damage on the endothelium, on podocyte, on proximal tubule. There might be mitochondrial dysfunction and acute tubular necrosis. Also, patients may be hypovolemic upon admission, and they may actually have a worsening renal function due to this effect. But there are other indirect situations, such as cytokine storm or cytokine release syndrome, pneumonia, and hypercoagulation. Now, first of all, pneumonia itself can cause an hyperinflammatory status, which can be worsened by the presence of mechanical ventilation or extracorporeal membrane oxygenation. And this may lead to acute kidney injury. In turn, acute kidney injury may actually cause hypervolemia and fluid overload and further impair pulmonary exchange. There are also hypercoagulable states that may cause endothelial damage, microthrombi, and kidney infarction, but also myocardial dysfunction, which can be aggravated by hypervolemia, but can also induce arterial underfilling because of low cardiac output state or presence of venous congestion that may impair kidney function. Finally, the cytokine release syndrome causing endothelial dysfunction may lead to a damage of the kidney and dysfunction, which is similar to the one we see typically in sepsis. So the rise of AKI biomarkers has identified stages in the continuum of AKI that can be identified by different biomarkers showing increased susceptibility, increasing early damage, increased early dysfunction, and finally progression towards kidney failure and death of the organ or even of the patient. The important thing is biomarkers are used to identify damage much before serum creatinine rise or GFR decrease, and these are molecules that are overexpressed by the kidney in presence of an early damage. There are also molecules that are expressed by cells in presence of stress even before the damage occurs, allowing us to somehow implement protective and preventive measures very early in the history of these patients. Another aspect that has been identified in COVID-19 patients is the so-called organ crosstalk. There are several organs involved in the general syndrome, and this may induce syndromes like hepatorenal syndrome, cardiorenal syndrome, or lung-kidney interaction. Given this concept, we proposed the utilization of extracorporeal organ support, ECHOS, which is basically composed by a series of modifications of the extracorporeal circuit that can provide lung support, cardiac support, can provide kidney support, can provide removal of cytokines, and provide support for the liver. This is extremely important because at the base of multiple organ dysfunction, we have the so-called cytokine storm. And the severity of disease depends on the interaction between the virus and the immune system of the host. And we will see how the response is involved in this syndrome. There is an early lung involvement with cough, fever, high ferritin, high inflammatory parameters, CRP, LDH, interleukin-1 beta, interleukin-6, 17, that may all be indications of an impending cytokine storm. Early treatment with anti-interleukin-6 drug has been tried and may prevent severe complications, but when patients are treated quite early. Finally, acute phase reactants, specifically ferritin, LDH, are available tests that may allow early recognition. But given that there is no pharmacological drug for COVID-19, we have no vaccine, do we have other options? And this is our question. Now, let's discuss a little bit about the concept of cytokine storm, which is basically an initial pro-inflammatory response due to innate immunity, which, however, is followed by a subsequent anti-inflammatory response syndrome that in many cases induce a kind of immunoparalysis. Now, the peaks of pro-inflammatory mediators and the peaks of anti-inflammatory mediators can be one after the others and may affect organ dysfunction. So the story of all this is that we cannot just block one of these molecules, but we need to block the entire spectrum of molecules. And this is where we publish in Nature the concept of using extracorporeal organ support to avoid kidney involvement in COVID-19 patients. Basically, there is infection, there is an immune response which is dysregulated, and there is organ damage. Cytokines are the key molecules in the immune response and organ damage, and thus removing cytokines by extracorporeal support can be a very interesting approach. Basically, the sequence of events that we see are viral infection, pneumonia, aggravated with inflammatory and anti-inflammatory response, endothelial dysfunction, and finally organ failure. At this point, if we can block the peaks of pro and anti-inflammatory mediators using extracorporeal removal techniques as hemoperfusion or hemofiltration, then we can induce endothelial protection and organ support. Of course, measuring cytokines in blood may be misleading because there is a very rapid cytokinetic flux from tissue to the intravascular space of cytokines, and therefore it is almost impossible to catch changes in concentration, but the effect on hemodynamics and inflammatory parameters is extremely clear. And we published, in fact, recently in Lancet some kind of guidelines for the management of acute kidney injury in patients with COVID-19, processing the entire aspect from indications for extracorporeal organ support, like oliguria, refractory hypervolemia, hyperkalemia, azotemia, going further towards preparation, prescription, delivery, and monitoring of the therapy. And here are down the different somehow description of the points that we need to provide for every one of these subsequent steps. Removal of cytokines can be provided with different methods, and in fact we can even try to remove viral particles that are circulating in the body. However, with the SARS-CoV-2, the level of viremia is very low, and this probably is not a treatment indicated as it is for Ebola virus or other viruses. However, we know about the molecules that are affecting inflammation, and they are all in the range of 40 to 60 molecular weight, 60,000 Daltons, describing their situation in terms of middle to large molecules, exactly those molecules that cannot be removed with classic dialysis membranes. For this reason, new membranes have been developed, like the medium cutoff membranes with increased porosity and increased size of the pores. And as you can see, the sieving curve of these membranes is dramatically different from the classic high flux membranes. Still keeping, however, the cutoff below the level of albumin, sparing albumin during treatments. So using high cutoff membrane could be a solution, but however, you have a leakage of albumin that may induce hypoalbuminemia, while HRO or medium cutoff membrane represent the very interesting solution. Another solution is to use surface modified membranes, which are characterized by large capacity of adsorption on top of the membrane surface. Some of them are modified with absorption of polyethylene imine and even heparin, inducing a specific bioactivity and capacity for absorption. And you see here in this slide the amount of cytokines that can be removed just by absorption on the surface of the membrane. This is the case of auxiliary membrane that we have used in COVID-19 patients. Now, this is extremely important because, in fact, with the organ crosstalk and the different extracorporeal organ support system, we can provide also the adsorption of this molecule, and adsorption can be provided by specific sorbents that are packed in specific beds inside devices like Cytosorb, for example, that can actually remove a large spectrum of molecules. We have to be, however, careful because they are also capable of removing hormones and drugs, and therefore we must adjust our therapies and our pharmacological approach to the possible removal by hemoperfusion. Others are special neutral microporous resins that are very biocompatible. As you can see, they are beads, very, very, very thin and very smooth, and they allow circulation of blood through them. And this has been a therapy utilized in COVID-19 patients in conjunction with CRRT. They can be used before the filter, or can be used after the filter, or they can even be used alone as isolated therapy directly into the circulation. Now, this is a very important possibility because it allows us to modulate the therapy based on the need of the specific patient. And this is a typical patient affected by COVID-19, admitted with fever, hypotension, respiratory failure, put in mechanical ventilation, and the patient becomes hemodynamically unstable with high cytokine level. It is then treated for 3 days with hemoperfusion adsorption, and after a few days, on day 8 and finally day 12, it goes into hemodynamic stabilization, normalization of cytokine levels, decrease of inflammatory parameters, and improved pulmonary exchanges. The most interesting aspect, however, is biological, the effect on reduction of cytokines, the improvement in the hemodynamic condition, and reduction in need of vasopressor support. Plus, there is an improvement in the phagocytic capacity and the production of cytokines by the monocyte when stimulated, showing that the monocyte that was paralyzed is finally recovering. And the demonstration for this is the improvement of HLA-DR expression, which is the capacity of the cell to present the antigen. So it shows that we are somehow reconstituting a normal immunological response, achieving what we call immunohomeostasis. So the tsunami led us to apply many of these therapies because many patients had severe condition associated with AKI, also patients receiving extracorporeal membrane oxygenation, and the adsorption can be used in parallel in the circuit of the oxygenator. This is a slide that will appear very soon in Nature. It's a result of a consensus conference that we did recently, where we start from the SARS-CoV-2 infection, and depending on the direction that the patient is taking towards hyperinflammation, towards sepsis, endotoxemia, or towards AKI, then the possibility is to use different type of extracorporeal support. And we use indication for mechanism of removal, target removal, duration, frequency, anticoagulation, blood flow, and many other aspects. We also have published in Blood Purification some expert review and recommendation on how to use renal replacement therapy and extracorporeal organ support in COVID-19 patients. And this is a take-home message from a very recent worldwide webinar that we had on COVID-19 patients with AKI and respiratory failure. There is a pathophysiological rationale for the use of hemoperfusion and absorption and removal of cytokines in COVID-19 patients with cytokine-induced hyperinflammatory syndrome. Cytokines represent possible target molecules for preventive and protective treatment based on extracorporeal removal. Studies should evaluate criteria for indication, initiation, duration of treatment, clinical and biological endpoint for efficacy measurement. We cannot use just mortality as an endpoint. We need to use endpoints that are meaningful to show that we can gain weight for other therapies to be effective. And the practical suggestion is to identify patients who possibly benefit, start early, monitor inflammatory parameters, and make sure you treat for at least 3 days our patient. You can follow part of my recommendation on a YouTube series called Cappuccino with Claudio Ronco. These are very short videos that you will enjoy. They are not just about COVID. They are not just about AKI. They are for our fellows all over the world. Our fellows used to say, Vicenza is a fantastic model. It's not a school of nephrology, it's a school of life. And in order to follow up with this, I invite you all to follow our Vicenza course that normally was held in May, but this year could not be held in person and will be held from November 3 to 5, 2020, virtually. It will be a series of webinar, expert review, pro-cons debates, and you can find easily information about our course on the website www.irriv.com, which is our research institute. Well, with this, I thank you very much, and I hope you enjoyed my presentation. Again, special greetings to my former co-fellows in GW, and a special homage to the American Association of Kidney Patients. I just want to tell you that I was privileged to receive the Medal of Honor by the American Association of Kidney Patients, and I'm very proud of this, having been identified as one of the doctors that contributed to the progress of the quality of life of our kidney patients. Thank you very much from Vicenza, Italy.
Dr. Ronco, thank you so much for your very informative presentation.